Good afternoon or morning, everyone, depending on what time zone you're in. My name is Lisa Dulce-Watkins, and I am the Director of the Milbank Memorial Fund Multi-State Collaborative, an organization of 17 states and regions actively participating in multi-payer primary care transformation. I'm also currently working with the Health Systems Transformation Team at the Association of State and Territorial Health Officials, ASTHO is our acronym, and I'm doing some work with them on the project that has brought us to this point today for this webinar. I'd like to welcome you to today's event. The name of this webinar is Maximizing Partnerships to Expand Care Coordination, Vermont's Hub and Spoke Model. And we're specifically looking at incredibly exciting innovations ongoing in the state of Vermont around treatment for individuals with opiate addiction. ASTHO, with funding from the de Beaumont Foundation and the Health Resources and Services Administration, HRSA, is working on several projects to promote partnerships between Medicaid and public health. In my work with ASTHO, I have been the lead writer on a series of case studies that are highlighting a collaboration between state Medicaid agencies and state public health departments that have either yielded or promised to yield cost savings to Medicaid or improvements to population health in the targeted population where the interventions have been focused. There will be 6 case studies featuring different topics and states. And one of the case studies that we are currently working on features Vermont's Medication-Assisted Treatment Program. This webinar helps to build on what we have learned during the development of the case study, and you'll be hearing from 2 of our experts and very important players in the process as it has unfolded in Vermont. Next slide, please. The objectives for this webinar are as follows. We would like to learn about how the Vermont Department of Health, the Public Health Department for the state, has successfully partnered with the Department of Vermont Health Access, which is Vermont's Medicaid agency, and the Vermont Blueprint for Health, a very important health reform innovation program that's been ongoing now for many years, as well as with other insurers to support the Hub and Spoke program that has been designed and now implemented to treat opiate-addicted individuals in our state. We're going to examine the role of public health in the care coordination model. We're going to identify ways in which public health can support data, quality, and care coordination for models such as the Hub and Spoke, and certainly for others extrapolating out into the broader world, and identify how this model has maximized the Medicaid reimbursement funding as well as using Medicare and private payers as a potential for the future. Next slide, please. I would love to introduce with great pleasure my friends and colleagues from Vermont who have agreed to share their wonderful expertise and experience with us today. This slide is a picture of Beth Tanzman, who is the Assistant Director of the Vermont Blueprint for Health. And she is a very important person in the statewide expansion of the Blueprint, which has led to the statewide Hub and Spoke program for opioid addiction, working specifically under the guise of the Vermont Department of Health Access, which is where the Blueprint resides, but also obviously very closely with her colleagues in the Department of Public Health. She has also led the development of a report about how adverse childhood experiences can be addressed through health services systems. Prior to joining the Blueprint, Beth served as Vermont's Deputy Commissioner for Mental Health and directed adult mental health services for the State Department of Mental Health for over a decade. Finally, in addition, she serves as a board chair for Elysium Incorporated, a peer-run crisis residential program in Rochester, Vermont. Thank you for joining us, Beth. And next, it's my pleasure to present my friend and colleague, Barbara Cimaglio. Barbara is a Deputy Commissioner for Alcohol and Drug Abuse Programs, known as ADAP, at the Vermont Department of Health. She is a nationally recognized leader in the field of alcohol and drug abuse prevention, treatment, and recovery. Her career spans almost 40 years of service at the state and local levels. Prior to joining the Vermont Department of Health in 2004, Ms. Cimaglio directed the Office of Alcohol and Drug Abuse Programs for the state of Oregon and held the position of Director of the Department of Alcoholism and Substance Abuse for the state of Illinois prior to that. If you have questions during this call, you're certainly welcome to post it to the chat box on the screen that you have at any time, and we will be collecting those and trying to address those in the question and answer session time of our session, which will be at the end of today's presentation. We'll also open up the phone lines during this question and answer session for you to ask additional questions or make remarks as they come up and as we can accommodate. At the conclusion of this call, you will be directed to an evaluation survey. Please, if you have the time and are inclined to do so, we would very much appreciate your taking the time to complete this survey. It will only take a few minutes, as we appreciate any feedback we can get from you in order to really make our future endeavors even more successful for ASTHO and for those of us in other organizations. So it's my great pleasure to turn the microphone over to my friend and colleague, Beth Tanzman.
Thank you, Lisa, for that nice introduction, and much appreciation, colleagues nationally, for the opportunity to speak with you a bit about what we're learning in Vermont as we implement our Hub and Spoke initiative, which is a partnership between our state Medicaid agency, our patient-centered medical home project, and our Department of Public Health. And we really consider this to be a work in progress, in that in no way do we think we have all of these complicated issues solved, but we have indeed been able to mount a significant new service intervention together and have learned much in the process. Next, please. One thing that really helps, I think, to organize a collaboration such as we're about to describe is to actually have a crisis or a problem that we can all organize around and respond to. And in the case of opioid addiction, Vermont, like many other states across the nation, is really facing what could be described as a perfect storm. We were seeing a combination of increasing rates of opioid addiction, both from prescription medication and also illicit drug use, inadequate network or health system capacity to actually meet the treatment demands. We lack both physicians in the outpatient settings and also struggle to be able to serve caseloads in our specialty addictions treatment settings. We were seeing very high healthcare expenditures of the people who, in fact, we had in treatment. Medicaid beneficiaries in Vermont who are receiving treatment for opioid addiction had on average 3 to 4 times the expenses of typical Medicaid beneficiaries. And not uncommon for complicated, co-occurring, complex chronic conditions, we are also seeing very poor health outcomes for these beneficiaries, not to mention poor other social indicators of outcomes, including increased rates of incarceration, increased rates of loss of parental custody, for instance, in the case of children and families. And furthermore, we were organized in a fashion that didn't really support integrated work, in that we had siloed programs both at the state level and also at the federal level. Okay, next slide. To say a little more about the silos, let me back up for just one moment and say that the good news was, when it comes to medication-assisted treatment for individuals with opioid addiction, was that we actually have an evidence-based treatment that works, that's generalizable, and that's scalable. And to just quickly define that for the audience, that is the combination of using psychosocial treatments in conjunction with medications to treat the addiction. And the medications used to treat this addiction have been organized at the federal level guided by 2 different sets of regulations, which tend to drive the creation of 2 different sets of programs at the community and state levels. And so, to be more specific, in the case of medication-assisted treatment for individuals with opioid addictions, One set of regulation governs specialty addiction treatment programs that are often called opioid treatment programs, where methadone is dispensed. They operate under very tight federal guidelines and protocol-driven procedures. They tend to be very specialized in providing only addictions treatment, and they are additionally regulated by our state substance abuse authority, which in this case, my partner Barbara Cimaglio directs. On the other side, beginning in 2000, by change in federal rule, any MD with a waiver may prescribe buprenorphine, which is another medication used to treat opioid addiction. So you see buprenorphine being prescribed in general office settings with, frankly, rather limited regulation. Any MD of specialization can provide this, provided they have completed this XDEA license. Their caseloads are capped, and typically these MDs will build existing medical evaluation and management procedure codes to pay for their services. As a practical matter in Vermont, what that meant was that our state Medicaid agency was the payer and the organizer, if you will, for the OBOT, or those office-based opioid treatment services. And our Division of Alcohol and Drug Abuse Programs, which is part of our state health department, was the payer and organizer for the methadone programs, the OTPs. And we came to call these methadone or opioid treatment programs our hubs, and these outpatient general medical settings our spokes. Next slide, please. One of the things that the Medicaid agency could bring to the partnership of working with the public health agency is a deep knowledge, obviously, about how to use the Medicaid program, and also our ability to respond to new opportunities. And under the Affordable Care Act, one of the options that Medicaid offices had was to expand and create a health home around Medicaid beneficiaries who have one chronic condition and are at risk of a second chronic condition. And in particular, the services that then could be provided through the Medicaid plan include a very deep raft of care coordination-like services. Specifically, the 6 core services are listed in this slide, and you see that most of them providing care management, care coordination, transitions of care, referral to community services are the toolbox that we would associate with providing care coordination around complex chronic conditions. And so we saw this as an opportunity to introduce coordinated care around Vermonters who were receiving medication-assisted treatment, either in specialty addiction treatment programs, hubs, or in the general medical settings, the spokes. Next slide, please. We also had an opportunity to build on our existing patient-centered medical home initiative, which is also housed in Vermont's Medicaid agency. And that, known as the Blueprint for Health, provides both service and payment reforms. Specifically, it pays all of Vermont's commercial and public payers pay primary care providers who meet the national patient-centered medical home standards more money, an additional per member per month payment for meeting the standards. And in addition, all the payers collectively support something called a community health team, which is a multidisciplinary team that works directly in primary care practices and with community partners to extend the reach of primary care. And so what we did was essentially design a Medicaid health home around beneficiaries receiving medication-assisted treatment that linked in a single framework our specialty addictions programs, the OTPs or hubs, but also provided additional resources and linkage to our primary care and other medical practices that were prescribing buprenorphine for medication-assisted treatment, and did it all in meaningful connection with our patient-centered medical homes and community health teams. Next slide, please. One of the things that we learned in speaking with the physicians who are prescribing buprenorphine in their typical settings was that the needs of the individuals with addiction really exceeded their current scope of practice. and that, however, if they were able to dedicate additional nursing and addictions mental health counseling to those patients, they could successfully manage care as they would other complex chronic diseases. And so what we did was build on our Blueprint community health teams and essentially provide a nurse and a licensed mental health addictions counselor for every 100 Medicaid beneficiaries receiving medication-assisted treatment in these OBOT or spoke programs. And that staff, that nurse and that counselor, are deployed to the individual practice settings and are part of the Blueprint community health team. And this allowed us to build the kind of supports to provide those health home services, the care coordination, transitions of care, and so forth, directly in the practices. Next slide, please. We also expanded the reach of our specialty addictions programs by developing new programs, enhancing their current resources with additional staff to also provide the same health home services that the nurses and mental health addictions clinicians are with the MDs prescribing buprenorphine. In addition, we had our specialty addiction treatment programs begin to dispense buprenorphine, one of the other major medications used, obviously, for medication-assisted treatment. And we also asked them to provide specialty addictions consultation to that network of spoke MDs or those medical practices prescribing buprenorphine, because often they really lacked access in a timely fashion to the depth of medical expertise in managing addiction. Next slide, please. We did do a few payment changes. This is, again, probably really warm to the hearts of our Medicaid partners here. We enhanced the bundled rate that the specialty addictions treatment programs were billing to include the health home services. We also increased the payments, the capacity-based payments for the community health teams to include the dollars to support the nurses and licensed mental health addictions clinicians working directly with the MDs prescribing buprenorphine. Next slide, please. To help organize our work together, both the Medicaid agency, the Blueprint, and our partners in the Public Health Department, Barbara and her team, set up a joint management structure for this hub and spoke initiative where we met regularly to both design the initiative and then continue to meet to get it implemented and to make any mid-course corrections as necessary. And I couldn't emphasize how important the direct face time was in working together to help support and manage the system of care that we were building. We've also convened regional meetings with stakeholders, both providers, and really worked hard to try to link the specialty addictions treatment programs to those MDs receiving spoke staffing and providing medication-assisted treatment. We've also together launched and sponsored a series of learning collaboratives with practice teams to help improve the state of practice in the communities. And we've also worked to have our staffs all meet together. Next slide, please. Just a few comments on some of the things that we've learned in our integration initiatives. First was that we have found that particularly with appropriate staffing, primary care can indeed manage complex mental health and substance abuse conditions such as opioid addiction. The protocols are not actually all that different from what you would do to manage chronic pain patients, and have some of the same kinds of follow-along and constancy of contact aspects that you might have for diabetes or asthma or other conditions. That it is incredibly important to support providers both in our specialty programs and also in the MD settings to have consistent, organized treatment protocols. We found that the teaming and administrative support is critical. The way a patient may behave with a physician could be quite different than how they might be interacting with the front desk staff. And unless the entire team in a practice or program is on board with why we're treating these individuals in a healthcare setting, they may not be able to respond in a appropriate fashion with patients coming in, and it can be complex. We found that having the extended staffing in these medical settings, the nurse, embedded nurse, and licensed addictions mental health counselor has been invaluable, and furthermore, they also help really forge the connection with the other treatment resources, including the specialty addictions practices. That it's been incredibly important that as a system, both our public health and our Medicaid agency collaborate together on making sure that the field has access to higher levels of care and higher levels of specialization when people need them. And one other point that many of the primary care physicians have made to me is that one advantage of treating individuals with opioid addiction is that you see them very frequently, and so you really truly build relationships with these individuals and their families. And when people get into stable recovery, it is extremely gratifying, and they may see progress in this cohort unlike what they would see for individuals with other chronic conditions. So this work has proved rewarding for our community. Thank you. I'll pause there and hand it back to Lisa and Barbara.
Beth, thank you so much for that informative and very wonderful presentation. Barbara, I'd like to turn to you to go through your presentation now.
Thank you, Lisa, and thank you, Beth, for the excellent foundation describing how we started this work together. What I'd like to focus on in my remarks to you today is a little more depth on how the public health side of the equation made a difference and was able to contribute in unique ways to this partnership. And I think you've already seen in Beth's presentation that much of what we do could not be done without a very deep and integrated approach to complex work. Next slide. So we began our work with opiate drug abuse by looking at all of the various facets in a comprehensive plan. And I think it's important to remember that treatment is just one aspect of a picture that is quite complex in responding to this problem. We do take a comprehensive approach. Public health has a underpinning of education, which includes prescriber education, community education. We also educate patients about the use of naloxone. The health department does serve as the single state agency for substance use disorders in the state, which means that we administer the block grant that comes from the federal government that requires us to develop a plan and build a comprehensive approach. We also have the opportunity to oversee the Vermont Prescription Monitoring Program, which is available in most states now under various authorities, but allows physicians to be able to know what medications their patients are being prescribed. We also have a strong partnership with law enforcement. That they do a lot of training in the communities. They inform many of our community coalitions about the problems that they're experiencing locally. We also have developed regulations in the health department for prescribing opiates, in addition to a regulation for physicians who prescribe buprenorphine, which I believe is unique to Vermont. There may be one or two other states that have developed a similar regulation, and that obviously is to ensure quality. We also focus on educating the community about proper medication disposal, which is an important part of keeping patients and community members safe by not allowing prescriptions to enter the market on the street, and helping with proper disposal is an important part of that. And then finally, you've heard already the development of the CARE Alliance for Opiate Addiction, which is part of our comprehensive approach to treatment that includes outpatient treatment, residential treatment, and a network of recovery centers. So I run through all of those elements because I want to underscore that the hub and spoke is successful in Vermont because it's embedded in a larger system. It's embedded in a public health system and in a medical home system that allows us to really build upon the unique characteristics of the partners and together build an integrated model. Next slide. I want to just apologize. They're doing some major construction work outside my office, and so if you hear some rumbling, I just want to apologize. There's nothing I can do about it, and it's outside. So how did we approach this integration? We used a traditional public health model. And I think it's important to remind those of you who are in the public health field that while this may be a bit unique for public health, it rests on the foundation that we use for any problem solving, which is we review the data. Our health surveillance department has the ability to do continual data analysis about the nature of the problem, what's going on in the community. This was very important when we were citing the locations for our hubs. We have greatly increased the amount of treatment we have available across Vermont, but we did that strategically by looking at where our population base was and what the most appropriate sites were for increasing access. This allowed us to work with our partners, as you've already heard. Developing the policy, as Beth mentioned, is critically important to make sure that we have a clear set of protocols and regulations underpinning this new model. And then the other roles of the health department help us, as I've mentioned, in implementing the program, whether it be our HIV network, our prescription monitoring, or our distribution of naloxone. These all help to support the hub and spoke that you've heard about. Obviously, evaluating outcomes goes right back to the data. Next slide. Under the policy development, I want to call out a couple of things that are particularly important. You've already heard about the Blueprint for Health and its policy of developing incentives for providers to improve their practice. In the health department, we've changed our policy on rates of reimbursement for our methadone treatment providers. When they turned into hubs, we were able to give them an enhanced rate by developing a new policy that would allow us to receive enhanced match. And then part of the work in progress, we're working more now with our accountable care organizations as they're looking at how they address various issues, but earlier intervention with addiction through screening with SBIRT, which stands for Screening, Brief Intervention, and Referral to Treatment. What we were finding is that many of the clients that were coming into the hubs were quite ill, and they really had not had medical intervention until their disease was quite advanced. So one of our goals now is to try to make sure that intervention is happening earlier and that we're also attending to screening in our primary care homes. Next slide. Just to summarize some of the things that we're striving for by using the health home model in our policy, improving access and integration clearly, in addition to promoting stable recovery. Next slide. I covered Espert, and I just want to also stress public awareness. One of the things in prevention, one of the things that we've been able to accomplish with creating a statewide network for opiate specialty care is linking more community development around the building of this model, whether it be educating physicians in a very particular training event or working with our community coalitions or our community collaborations around health. The primary point of the awareness is to help people understand more about addiction. When we began this model, we found that many people had misinformation about addiction, what it is, what you do to treat it. They had a lot of ideas about who the patients were going to be, and so public awareness became a very important part of setting the foundation and continues to be a very important part of our public speaking about this model. Next slide. This gives you a picture. This on the right is the state of Vermont, and the dots point out the 5 region, or there's the 6. One region has 2 sites. So the locations of our hubs, and around those hubs there is the network of spoke physicians, which includes primary care doctors, family doctors, pediatricians, federally qualified health centers. They come in many forms, but they're all linked together and work with their community health teams. The key elements, just to underscore, in this model, a physician-led medical home, a single provider to whom the patient is responsible for care coordination. All of the patients have a pharmacy home, so they're only getting their prescriptions or their medications in one place, whether it be through prescription or the actual hub dispensing. The access to the community health team and the wraparound services provided by the nurses or the clinicians, and obviously comprehensive medical care. Next slide. One of the other key elements, in addition to the standardization of procedures and protocols that I'd call out, is the linkage to recovery coaching. An important part of helping someone maintain stability and long-term recovery is the link to the recovery community. Medication-assisted treatment, counseling are very important parts for establishing stability in a patient's life, but to promote long-term recovery from the disease of addiction, it requires additional supports in the community, which Vermont has done through building a network of recovery centers that provide coaching and support and often help a patient when they're working through some of their struggles, making sure they're making their appointments on time. Just like with any other chronic disease, peer support is emerging as a very critical element for maintaining long-term recovery. Next slide. Training has been a very important part of what has helped this system grow and thrive, both improving primary care knowledge of how to manage pain and addiction, as well as having people learn about the proper treatment for addiction in the collaboration that Beth mentioned through the Learning Collaboratives. We've appreciated our strong partnership with Dartmouth as they have been a very key player in helping us develop protocols and then training those protocols through the Learning Collaboratives at a regional level. And I think it's another point to be made that working with the university community, can really help advance a complex initiative because they have resources that can enhance the ability to spread the model. And then next slide. Regulation. I mentioned earlier we developed 2 key rules that go along with the implementation of this model. One is a medication-assisted treatment rule, which governs the behaviors of the physicians who are prescribing medication-assisted treatment in their practice. And the other is the Unified Pain Management Rule, which establishes elements that need to be in place for any physician who is prescribing opiates in the treatment of chronic non-cancer pain. And it includes things like using the prescription monitoring program, having a patient contract, the requirement to do urinalysis screening, having pill counts, and referring if there's a risk detected of possible addiction. Next slide. On this next slide, there are links to the rules that we've promulgated if anyone is interested in looking at those in a deeper way. And then finally, next slide, measuring outcomes. We're looking at, again, back to public health. We do the Youth Risk Behavior Survey and the Adult Behavior Risk Survey. We do use those surveys to look at how we're doing. Is our problem getting better? Is it staying the same? So we do have a dashboard where we look at how we're progressing. We use local surveys in the communities and as well, and that helps the local area understand how they're progressing in the problem. Finally, improving access to care. We have gone from just a few years ago, well, it's been more than a few, but in the early 2000s when we first began delivering medication-assisted treatment, we started with 100 slots for the whole state. And we're now, between the hub and the spoke, so through the OTPs and the office-based treatment, we're serving over 5,000 patients. So this systematic approach focusing on partnership has improved access, which was the primary reason we did this. We're also seeing preliminary results showing lowered health costs and obviously improving patient functioning. So we are seeing we're moving in the right direction. And last slide then. What's working well is that we have successfully created a statewide coverage model. It's not perfect. As Beth said, it's a work in progress. We have gaps. We have areas where we struggle in finding physicians. But basically, we have rolled this out to the whole state. We've demonstrated that we can integrate primary care with addiction specialty treatment. We've developed a comprehensive care model for addiction, and we've also developed a bundled payment model that is working to help patients receive not just the minimal basic services, but also enhanced health home services and linkage to recovery. Thank you very much for the opportunity to share some of what we've learned with you today. And I'll turn it back over to Lisa.
Thank you so much, both Barbara Cimaglio and Beth Tanzman, for really wonderful presentations about a truly cutting-edge program in Vermont, about which you should be justifiably very excited and proud. So thank you for taking the time to share that with our audience today. At this point, we'd like to open up the line for any questions. So there are 2 ways to do that. You have the opportunity of typing in questions into the chat box that's on the bottom left of your screen. And we'll also can use the phone lines, and the operator can give instructions to our participants for how to do that. So if I can turn to that.
If you would like to ask a question via the phone, please press star, then the number 1 on your telephone keypad. Again, to ask a question via the phone, please press star, then the number 1 on your telephone keypad. We'll pause for a moment to compile the Q&A roster.
Well, so while we're waiting, it sounds like people are thinking perhaps about what they'd like to explore a little more deeply. There was a question that we thought would be of interest specifically to Barbara, which is how a public health organization can support an approach like this if you are not actually tasked as the lead agency for substance abuse treatment. So Barbara, would you like to address that briefly for our audience?
Sure. Thank you very much. I think you heard in both Beth and my comments that we're very fortunate here in Vermont that we have good partnerships in place. I think for those folks who are in larger states or communities and may not have all of the partners working together, I have learned nothing if I haven't learned the importance of developing a very good partnership with the medical community as well as with the Medicaid community, people doing healthcare reform. Many people in the addiction field can be kind of isolated. You know, it has been a field that has been sort of carved out for many years. So when we embarked upon this work together, we weren't quite sure how people were going to respond to working more in a team and as partners. But it's been so rewarding to see that the successes we've had have only been because of these strong partnerships. So I would encourage anyone who's interested in exploring more of this kind of work to start with really getting to know the partners that can make a difference and making sure that each side understands each other's world and what's important and how to use the tools that are available depending on where you sit. Thank you.
Thank you, Barbara.
There are no phone questions.
I'm sorry?
There are no phone questions.
Thank you very much. I think, Barbara, your comments really resonate with me as we are working on our series of case studies, because there's no question that a combination of developing professional working relationships is extraordinarily important so that people actually do know each other. And we are developing what we're referring to as sort of 101 documents for both Medicaid agencies and departments of public health, whether at the state or more regional level, so that people can have perhaps a better understanding of some of the basic pieces of the details of their work. Because often the vocabulary is different, the language can be different. So this is a great example of how that divide was transcended to some degree, and how it continues to take work to work fruitfully together. There have been a couple of questions that came in on our chat line, and one of the first questions, and I think I'll direct this to Beth initially, is how the work was done to engage legislators in the initiative in terms of getting that kind of support at that level of state government.
That's a wonderful question, and obviously we couldn't have done this work without the support of our executive and legislative branch. Legislators in Vermont and our citizen legislature were somewhat aware, some acutely aware of sort of the depth of the crisis or problem we were having in Vermont regarding opioid addiction. So they were actually hearing, I think, more about the problem, whether it was difficulties in access to treatment, whether it was difficulties with local law enforcement experiencing increased rates of burglary and theft, or looking at increased incarcerations, or also through our Department of Children and Family Services, seeing the toll that addiction takes on young parenting families. So I think that people were actually hungry for a solution to help address it. Another thing that was tremendously helpful to us was we used the state plan amendment to create a health home for this initiative as essentially bridge funding. And so the ask that we were essentially making to the legislature was not, at least initially, for significant new appropriations. Rather, we were able to financially model the initiative in a way that was cost neutral for at least the first 2 years. And that gives us an opportunity to stand up the services footprint, both in the opioid treatment programs, the hubs, and also in the spokes, which in turn is helping to drive down our other healthcare and other social costs. So one important strategy was having a clear staffing and cost model, but being able to at least implement that initially in a cost-neutral fashion. That combination of here's a solution to this problem as far as treatment goes, or at least a good start on a solution, and we can do it in a way that's almost cost-neutral to Vermonters, was very attractive to legislators.
Thank you, Beth. Next question is talking about a specific example of a rural health clinic, and what is understandably, I think, seems like a big burden in terms of looking at the substance abuse treatment added to an already overburdened organization. Beth, would you like to
Yes, let me, by virtue of the nature of our state, almost all of our providers would count as rural providers, including in our small practices, our federally qualified health centers, and so forth. And one of the things that the providers really told us that they were struggling with was that these patients need to be seen more frequently, and they require more complex nursing follow-up. And they were also concerned that the individuals with addiction may not actually be successfully getting connected to addictions and mental health specialty treatment. And so if they could have that addictions and mental health counselor working right in their practice, that could make a tremendous difference. So, for example, the way that the patient panel has been set up in many of our more rural primary care practices is that the physician agreed to schedule the patients whom he or she is treating for medication-assisted treatment on a certain set morning or afternoon of the week. And the physician actually has the patients first see the spoke nurse and or the spoke counselor before coming to touch base with the physician. And if the patient is doing well and nothing further is needed, they don't even need to see the physician that visit. But if there is a physician intervention that seems appropriate, perhaps a change in the prescribing, then that visit is already teed up and started for the physician. So the additional staff had the impact of really helping to free physician time in the management of these patients, and also to really demonstrably augment the strength or the resources that the whole practice team had to manage addictions. I'll pause there.
Thank you, Beth. I'd like to move on to another question, just trying to be cognizant of the time. A question has been raised about the work being involved with substance treatment regarding exposed pregnancies. And just as an aside, I'd like to point out that the chairperson has sent out a link to the ASTHO Neonatal Abstinence Syndrome report, and the website has that information on it. But Barbara, I thought maybe you would like to address that question, and it specifically looking at the idea of engaging providers. Obviously, this would be obstetrical and gynecologic providers in this setting, as well as family medicine. So if you wanted to address that question.
Sure. Thank you, Lisa. Yes, I think I have a couple of comments on that. One, obviously being in a public health department, we have maternal and child health under our umbrella. So we have an advantage of being able to work with our maternal child health partners, and that brings us in close contact with pediatricians, obstetricians, and so forth. So that's a real advantage of bringing this work into the public health world. The other thing I think is that specialty care of another kind is definitely required for working with pregnant women. By federal mandate for any methadone clinic, pregnant women are a priority population. So they are the first in line to get treatment. And we've worked diligently to develop teams that can work with complex women and families, especially when there's an affected newborn that obviously needs extended care in a neonatal unit. But the importance is to maintain the mother in treatment and to make sure that she remains stable so that, whatever else happens, she is able to continue in treatment. It's been a struggle in a rural area because we don't have a lot of specialty obstetrical practices, but we have a few wonderful champions. And here again, I would give a shout out to our physicians who have just been tireless in their dedication to this population. So again, forming those relationships and finding some champions who are willing to specialize with this complex population really makes a big difference.
I would just add, this is Beth speaking, that some of our larger OBGYN providers are also prescribers of medication-assisted treatment, and they've been real clinical leaders for us on this. And so we embed the nurse and counselor in those practices just as we would in any other setting. And they find that with good support and staffing throughout the pregnancy, the use of buprenorphine, for instance, babies are born, in fact, with very successful full-term pregnancies, full birthright babies. And so, again, as Barbara emphasized, the importance of keeping the moms in treatment and moms stable has led to much more successful outcomes for these newborns.
Thanks to both of you, and it's just such a wonderful example of the success that this initiative can have, and really we're thinking about prevention in a very tangible way with really working with people in their pregnancies as well as then immediately after with the goal of having healthy babies. Well, on that note, I would like to end our Q&A session. If you have any follow-up questions, please use the contact information that's on the screen now. You can see my name, Beth, Barbara's, and some of our colleagues, Megan Miller and Courtney Bartlett at ASTHO, are on there. Feel free to contact us with further questions. So thank you very much for joining us today. The archive of the webinar and additional resources will be posted on ASTHO's website, which you see here below, which is, as I was mentioned earlier, you will be immediately directed to an evaluation at the conclusion of today's call. We would very much appreciate your taking these few minutes to complete our survey, as it provides us with very useful information to improve on and shape our future projects. I would like to thank the Health Resources and Services Administration and the de Beaumont Foundation for generously sponsoring this webinar, and also to our speakers from Vermont, Beth Tanzman and Barbara Cimaglio, for their very informative and well-done presentation. Thank you so much. A recording of today's call will be available on the website within the next couple of weeks, and the web address is on your screen right now, as you see. We hope that you will be able to use this webinar as a resource, and we'll share the link with others once it becomes available. Thank you so much for participating today, and enjoy the rest of your day.